Hello everyone. So in this video, I'm going to walk you through a real life high risk inpatient case that highlights how complex and unpredictable hospital medicine can be. So this was about 81-year-old male with history of lung cancer who was admitted, and the admission began with nausea and vomiting, just with nausea and vomiting. But then it quickly evolved into cascade of serious complication. So this is a case about 81-year-old male with a history of lung cancer who got infection, GI bleed, and readmission. And I saw this patient only for 3 days. But when I took over this case, this patient has almost 1.5 month medical history, which was there. For patient was admitted, discharged, and then got readmitted. So for some of us, this will be a very interesting case and learning experience, and I hope you guys will learn from it also. So this is my topic is basically a diagnostic and management challenge uh, in 81-year-old male with history of lung cancer who got GI bleed and got readmitted. So this patient profile was he was 81-year-old male, and he has history of stage 3 squamous cell carcinoma of the right lung who got chemoradiation and immunotherapy. So his last chemo dose was November 20. He received cisplatin and paclitaxel. And the side effect of these two chemo is we know that it can cause nausea, vomiting, diarrhea, and anemia. These are the side effect of these chemotherapies. This patient also had a history of COPD, chronic respiratory failure. He used to use 3-liter oxygen. He has CKD stage 3B, and his baseline creatinine was about 2. He has a history of AAA repair with endograft back in 2021, and he also had a history of splenectomy back in 2020 after motor vehicle accident. He has a history of type 2 diabetes, hypertension, and hypothyroidism. So this was the patient profile, his past medical history, and he came to us on November 11. So he was first time seen in the hospital on November 11, and he came in with intractable nausea, vomiting, diarrhea, abdominal pain, and his most recent chemo was the month before on October 27, almost like 2 to 3 weeks ago, with cisplatin and paclitaxel, and he also recently had rhinovirus infection. So patient came in with nausea, vomiting, diarrhea, abdominal pain. He was having poor oral intake, and he was very weak. He had functional decline. So on initial admission, his vitals were stable, except the low blood pressure which was there. Blood pressure was slightly low, but otherwise stable. So his hemoglobin on admission was 9. We don't have any previous hemoglobin. And on chemistry, his creatinine was 2.5, baseline was 2, and his bicarb was 18. So he was acidotic. So he was having vomiting, diarrhea, abdominal pain. So the team they did the GI PCR panel for the stool because he was immunocompromised because of the cancer and chemotherapy, and the stool was negative for C. diff and other GI viruses. They also checked the lactic acid. Lactic acid was normal. In the ED, they did the CT scan of the abdomen and CT scan of the abdomen without contrast because he has CKD. So that was also negative. So the treatment was started. They thought that okay, maybe it's all because of the chemotherapy and rhinovirus recently. Maybe that's why his patient is having these symptoms. So they start the patient on IV fluid, nausea medication, and they said we'll repeat the blood work again next day. So that was the initial presentation. Nausea, vomiting, diarrhea, abdominal pain. Initial blood work was okay. But now these symptoms continue. So patient continue to have nausea, vomiting, diarrhea, abdominal pain. Uh, the imaging was negative, stool studies were negative, but these symptoms continue. And eventually the team decided to consult GI fast forward. So on November 16, GI, they decided to do EGD because of nausea, vomiting, and abdominal pain. And they found large distal esophageal ulcer with gastritis. So we thought, okay, we have a diagnosis. Maybe it was not associated with chemo, but maybe it was associated with chemo plus this ulcer also. And patient was started on PPI, proton pump inhibitor, IV, 40 milligram BID. Protonics was started, but symptoms persist. So patient was started on protonics, IV, BID, but patient continued to have intractable nausea, vomiting, abdominal pain, and those symptoms continue. So moving forward, so patient continue to have those symptoms along with diarrhea. GI thought that okay, uh, maybe this is because of the esophageal ulcer, and the ulcer is deep in the esophagus. They thought that okay, maybe we should add sucralfate or carafate, which will help to cover the ulcer. Maybe it will cover the lining of the esophagus. So they added carafate. So the carafate was started, but patient was not able to tolerate carafate. Not able to tolerate, and symptoms continue. Symptoms even got worse. Patient continued to have severe abdominal pain, and carafate was stopped. GI was consulted again. So GI did the scope on 16. Patient symptoms does not improve. Carafate stopped. Patient was getting on and off pain medications. We were making sure that okay, patient should not get any NSAID. And GI said that okay, this ulcer is not healing, and this patient might need PEG tube placement. And on November 23rd, and I'm telling you that all these dates are fake. We are hiding the patient identity. So, but overall, the hospital course was very similar. So on November 23rd, GI decided to put the PEG tube or G tube placement, and the idea was that okay, we will let the ulcer heal and try to avoid the irritation of the esophagus. And PEG tube was placed on 23rd, and patient was started on tube feed. So this was done because of persistent nausea, vomiting, abdominal pain, and diarrhea. On 23rd, PEG tube was placed. On 24th, patient after the PEG tube was placed, the next day after the PEG tube was placed, patient developed worsening of hypoxia, and he was requiring up to 6 liter with nasal cannula. That was the first time when CT scan of the chest was done, and that was showing cavitary lesion, which is concerning for necrotizing pneumonia. We all know that sometimes bad infection can also cause nausea, vomiting, and diarrhea, which are the systemic symptoms of infection. Obviously, no doubt we could not explain about the abdominal pain, which could be related to ulcer, but sometimes the systemic symptoms can happen with nausea, vomiting, and diarrhea related to infection. So there was the first time when necrotizing pneumonia was diagnosed, and the CT scan of the chest was done because patient was having increased oxygen requirement. So patient was started on broad spectrum antibiotic, vancomycin and meropenem. Why meropenem? because patient was allergic to penicillin and the allergic reaction was anaphylaxis. So that's why patient was started on meropenem. All the cultures were sent, sputum gram stain and culture, pneumonia PCR panel, atypicals, they were all ordered. So pneumonia PCR panel, it came back positive for Pseudomonas, Streptococcus agalacti, Staphylococcus, Klebsiella, and E. coli. And then blood cultures were also done, and the blood culture, 1 out of 2 bottles were positive for Staph aureus. So vancomycin and meropenem, they were continued. So patient was diagnosed with pneumonia, necrotizing pneumonia first time on November 24th. And on November 24th, the same day, patient developed abnormal rhythm of the heart. EKG was done, and that was showing SVT. And metoprolol was increased to 100 BID, and cardio was also involved. Cardiology was consulted. And when the patient was diagnosed with necrotizing pneumonia, pulmonology was involved at that time. On the same day, on November 24, patient developed brief episode of unresponsiveness with right upper extremity weakness, and the same day, code stroke was also called. CT scan of the brain was negative, and stat MRI of the brain showed subacute to chronic ischemic stroke, and neurology was consulted. Neurology recommended that it may be subacute to chronic ischemic stroke. So patient recently had a GI bleed. Last EGD was done on 16th of November. So they said we cannot start dual antiplatelet like aspirin or aspirin and Plavix. They said maybe we can start this patient on aspirin only and monitor for GI bleed symptoms very closely. And then they also recommended to find out the cause of stroke. We can plan for 30 days Holter monitor. We also did the echocardiogram, and echocardiogram was normal. Reserve EF, maybe grade 1 diastolic dysfunction. So patient was started on aspirin, and patient continued to stay very weak. And then patient was started on tube feed. He was not able to tolerate tube feed very well. So he was having intermittent nausea and abdominal pain for the next 3 days. And on November 28, patient developed large volume melena and hematochezia. And again, GI was consulted there. GI, they did the EGD again, and they found duodenal dephloid lesion, which was treated endoscopically, and they also did the colonoscopy at the same time, which showed a couple of polyps, 2 polyps in the colon, which were removed, and then 2 hemoclips were placed. And then moving fast forward, patient was getting the treatment for pneumonia with antibiotic. Patient was getting the treatment for stroke with aspirin, but then aspirin was stopped because patient developed melena and hematochezia and GI bleed again. So aspirin was stopped. And then patient developed GI bleed again, hematemesis. And GI who was following the patient, they did the repeat EGD again on December 6th. So this was basically the third EGD. The first one was done on 16, second was done on 27, and then third was done on December 6th, which again showed dephloid lesion in the duodenum. GI recommended that we should continue protonics, 40 IV BID, and then hold caraphate, stop any medication which can cause GI symptom, which patient was not on any, and then GI signed off. This patient was eventually discharged on December 13. So he was initially have poor tolerance to bolus feed, tube feed, because he had a tube feed. So he was transitioned to continuous tube feeding. He was started on Jevity and he was discharged on December 13, and he was discharged to skilled nursing facility to get rehab. Now on December 20th, this patient went to cardiology clinic because he has an appointment. He recently had a SVT episode. So he went to cardiology clinic and he was feeling very weak and tired. He was very exhausted. They did the vitals and he was tachycardic. Cardiology, they call uh, the medicine floor and they said that this patient need to be admitted. So because of tachycardia and generalized weakness, initial workup started with CT angio to rule out PE, which was negative, and it was also showing stable multifocal necrotizing pneumonia, for which he already finished the course of antibiotic during last time. But still, because he was feeling weak, patient was started on empiric antibiotic, which was later discontinued. And pulmonology, they were consulted and they said, let's monitor the patient without antibiotic. So patient also had a CBC chemistry. His hemoglobin was stable around 9.8. So there was no concern for GI bleed. His creatinine was around 2, which was his baseline. His bicarb was 21. Sodium, potassium, they were normal. So we also checked procalcitonin, that was normal, less concern for infection. Pulmonology, they recommended that let's repeat the CT scan of the chest in 8 to 12 weeks. And the plan was, because everything was normal, the only thing was weakness. The plan was to discharge the patient back to rehab with tube feed, and we will repeat the CT scan of the chest in 8 weeks. And we'll continue the protonics. So that was the plan. But on December 21st, it was my first day with this patient. And that was a time when I actually look at all this hospital course. There was a sign out given to me that, okay, this is the plan, everything is stable. I started my first day, I was happy. I saw a long hospital course, and that took me some time. So I took a deep breath in the morning. I said, okay, who will read all this course? But it was worth reading. So I look at the labs in the morning and they were all normal. I talked to the patient, he was doing fine. I was happy. I said, okay, hemoglobin is 9.9, hemoglobin is stable, kidney is stable, patient is getting tube feed, he's tolerating it well. So that was my day one with the patient. It was a weekend, and the plan was to discharge the patient back to rehab, and that was my day one. So I had a summary in my head, and let me go over the summary with you so that you can also have an idea what happened to this patient during the last 1 month. So this was an 81-year-old man with a history of lung cancer who got a chemoradiation and was planning to get immunotherapy. He has multiple comorbidities. He was hospitalized in November and December for intractable nausea, vomiting, and diarrhea. Initially, it was thought to be secondary to chemo and rhinovirus, but then his course was complicated by severe esophagitis with ulceration, esophageal ulceration, which was requiring PEG tube placement. The hospital course was complicated with necrotizing pneumonia with worsening hypoxia, which was treated with broad spectrum antibiotic, and then he developed paroxysmal SVT, treated with beta blocker, and then the core stroke was called, and he was diagnosed with stroke. And then after that, he subsequently developed recurrent GI bleed, and EGD was showing duodenal defloy lesion, and colonoscopy showed polyps. So he had multiple endoscopic intervention and interruption of antiplatelet therapy because of that, which was given for stroke. After stabilization, patient was discharged to skilled nursing facility on tube feeding and was readmitted again on December 20th because of tachycardia weakness. So he was all stable. CT scan, CT angio was negative for PE, and pulmonology recommended to monitor without antibiotics. So that was a summary in my head on day one. So on December 22nd, my day two, patient started having abdominal pain again, which was mild, and it was associated with some nausea. On that day in the morning, I look at the hemoglobin, it was same 9.8, creatinine was stable, so CBC chemistry was normal. Just to be on the safe side, I thought, okay, let's get the X-ray KUB because this patient has multiple comorbidities. Let's make sure everything is okay. I did my exam. He has a mild abdominal tenderness on the left side, and we did the X-ray KUB, which came back normal. So that was in the morning, around 9 o'clock. And then we look at the vitals. Vitals were all normal. Patient was saying, I have some abdominal discomfort, but he said it's not very bad. It's all okay. So around noon time, patient continued to have this abdominal pain, and I started thinking about other things also. I said, okay, let's try to rule out inferior wall MI. So we get the EKG, and I also got the stat troponin. So EKG was normal, and then troponin was also flat. It was also normal. Then I thought about uh, maybe he's having some uh, abdominal pain, maybe some clotting phenomena going on. So that was so basically in the evening, around I would say maybe 5 o'clock. They said this patient is having increased work of breathing. He's having shortness of breath. So that was a point. Basically, in the evening, I ordered D dimer, and that was normal. Because we could not get CT angio because he has CKD. So I ordered lower extremity Doppler, and that came back negative for DVT. Because of increased work of breathing, so he was initially started on high flow. I ordered the chest X-ray. Chest X-ray was normal. CT scan of the chest without contrast was also done, and that was showing stable recent pneumonia. So we ordered some pain medication, and I told the night team that maybe we should go order the VQ scan also. So VQ scan was done, and that was negative for PE. Now in the evening, later in the evening, I would say maybe around 9 o'clock or 10 o'clock, patient abdominal pain continues. He continued to have increased work of breathing, also shortness of breath. He was started on high flow oxygen. So we were not sure what was going on. And night team also got the CT scan of the abdomen without contrast. So X-ray KUB was normal. They did the CT scan of the abdomen without contrast. Again, that came back normal. So overnight, because of increased work of breathing, he was started on high flow. He was up to 40-liter oxygen and 60% FiO2 he went up to. So because of that, increased work of breathing, increased oxygen requirement, increased abdominal pain, he was transferred to step down floor. And we already know that his VQ scan is negative. He was hemodynamically stable, vitals were stable. He continued to have shortness of breath, abdominal pain. Night team also got CBC and chemistry again, And because they were thinking that he's having abdominal pain, he has a recent history of esophageal ulcer, which was bleeding again and again. He has defloral lesion. They thought, okay, maybe he's having bleeding again. Maybe he has esophageal rupture. Um but imaging CT scan of the abdomen was normal. CBC, BMP chemistry both came back normal. They also checked the lactic acid, and lactic acid was also normal. Now this is my day three, and I started my day with the night team gave me the sign out that this patient is not doing good, something is going on. So without going over uh, other patients, I went to the patient chart and started with him. And right after I reviewed the chart, I went to the bedside and saw the patient. So this patient was having severe respiratory distress. He was having increased work of breathing. So I told the nurses, okay, let's start this patient on BiPAP, and I ordered the stat VBG. He was also complaining of chest pain at the same time. He was oriented times 3, by the way. His vitals were all stable. His blood pressure was, I remember, it was actually 145 over 85. That was his blood pressure. He was requiring a lot of oxygen. He was on 40 liter and 60% FiO2, high flow. I started him on BiPAP to decrease the work of breathing, and I also got the EKG and stat troponin again, both of which came back normal. His VBG came back, it was pH of 7.44, and PCO2 was about 47, so it was not too bad. And then patient mentioned that he's having abdominal pain. So I did the exam, and then he was complaining of some lower abdominal tenderness. He was not making a lot of urine, so we did the bladder scan. It was showing 450 cc, so the Foley catheter was placed, and we thought, okay, maybe abdominal pain is because of the urinary retention. Again, that morning on day 3, when I was looking at the CBC and BMP, his white cells jump up to 28,000, which were normal the day before, and his creatinine jumped from 2 to 2.7. And when I look at the blood work in the morning, I started this patient on broad spectrum antibiotic again. So I added meropenem, and patient was started on vancomycin, and we also added doxycycline, broad spectrum antibiotic which covered with everything. I ordered the stat lactic acid, and lactic acid was 2.2. It was not too bad. So while I was in the room talking to the patient was complaining of abdominal pain. He was moaning. He was complaining of some chest pain. Uh, Patient immediately, suddenly become hemodynamically unstable. His blood pressure actually dropped from 145 to 76 systolic. And I recommended 1 liter LR bolus. And then I immediately call ICU intensivist that, okay, we have to transfer this patient to ICU. And after I talked to intensivist, he was immediately there, and they said, okay, this patient require pressor medication. And while we were having that discussion there, uh, at that point, because patient was having abdominal pain and he was hemodynamically unstable, I decided to consult surgery to evaluate the patient, because we were concerned about bowel ischemia. And the stat surgical consult was placed. Surgery was in the hospital. They immediately ran to the room, and they talked to the patient, and they said, okay, there are multiple comorbidities, but the suspicion for bowel ischemia is very high considering the history of recent GI bleed. He's hemodynamically unstable. He has a history of aortic graft in the past. Back in 2021, he's immunocompromised, and that patient actually went to expiratory laparotomy and diagnosed with bowel ischemia. So they did the bowel resection, and after that, this patient slowly gets better. So after the bowel resection, obviously he was intubated. Then he went to ICU. He was started on slowly. He started on tube feed eventually, uh, and then he's continued to get better slowly. And then he almost stayed in the hospital for another month. But then he was eventually discharged. But that's how the diagnosis of bowel ischemia was made. So it was a very, very vague situation, but a very complex situation. Um, but the diagnosis of bowel ischemia is like that. So you need to have a very high degree of suspicion in your head to make a diagnosis. And sometime everything is looking fine, all the labs are looking okay, and if you have a suspicion, you need to consult surgery, and they have to do the expiratory laparotomy to make this diagnosis. So let me give you some important points, some important tips based on evidence that how to make a diagnosis of bowel ischemia. What should be your diagnostic algorithm? Any patient with bowel symptoms, like nausea, vomiting, diarrhea, GI bleed, or sepsis of unclear source, or patient with altered mental status who is elderly, you should have this diagnosis in your head always. Any patient with GI symptoms, you should think about bowel ischemia. You should always have this diagnosis in your head. So once you have this diagnosis, and once you think that patient is not getting better, the next step you should look for is start looking for risks. What are the risk factors? So the first risk factor is age greater than 60, history of AFib, history of hypotension or shock which our patient developed, vasopressor, our patient started on levofed, then history of coronary artery disease, heart failure, hypercoagulable state, history of cocaine use, amphetamine use. So start looking for risk factor. Any patient with GI symptoms not improving, start looking for risk factors. Now, if the patient has greater than one risk factor, then you have to go to the bedside and assess the patient. And the most important physical exam finding is pain out of proportion to the physical finding. So when you examine the patient, they'll complain of a lot of pain, or they will say that they have too much pain, and you are unable to explain that pain, abdominal pain. You should have a suspicion. That's a red flag. If the patient has unexplained ileus, if the patient has bloody diarrhea, if they have lactic acidosis or acidosis on chemistry, you don't have to wait for the labs. You need a high degree of clinical suspicion. So let's say if your clinical suspicion is high, you should immediately order CT angio. So we were not able to order CT angio on our patient because his creatinine was bad. So he has CKD stage 3. So, and he was having GI bleed, he was having cardiac symptoms, cold stroke. So he has multiple comorbidities. So we wanted to save his kidney also. So we did not order CT angio in our patient. But let's say if the kidney is okay and your suspicion is high, you should order CT angio, and it can sometimes give you a diagnosis of superior mesenteric artery embolus, patchy ball ischemia. But now let's say if the CT angio is normal, that is a very, very tricky point, because that's where you will diagnose a lot of patient, and that's how it is common. Commonly you will see your patient fall into this category, that your patient has normal CT scan, but then you need to have a high degree of suspicion. So let's say if it is normal, your suspicion is high, I will say actually repeat all labs and CT angio imaging within 12 hours. If there is any change, let's say if the patient become hemodynamically unstable in next 2 hour, 3 hour, or 4 hour, let's say 6 hour, 10 hour, repeat all the labs, CBC, BMP, lactic acid, imaging, repeat all of them. And if that is positive, then you will have a diagnosis. Lactic acid usually rise late. when the patient develop bowel ischemia. So you have to have a high degree of suspicion. And let's say if you're still not able to explain, then always consult surgery for exploratory laparotomy. Our patient has a lactic acid was only 2.2, and when they took the patient down for surgery, he had bowel ischemia. So this was our complex case. It was a learning experience, and everyone effort. So GI was there, critical care was there, pulmonology was there, infectious disease was there, neurologist was there, and then the surgeon. So it was a combined effort which led to the diagnosis of this bowel ischemia eventually, and then that saved the patient life. Work as a team and help your patient. I hope you like this case and it was a learning experience for you also. Thank you. Have a nice day.